Hi, I'm Sarah Trott, and welcome to the Fourth Trimester Podcast. I'm a new mama, and this podcast is all about postpartum care for the first few months following birth, the time period also known as the fourth trimester. My postpartum doula, Esther Gallagher, is my co-host. She's a mother, grandmother, perinatal educator, birth and postpartum care provider. Fourth trimester care, our topic, is about the practical, emotional, and social support parents and baby require. And importantly, it helps set the tone for the continuing journey of parenting. Hi, this is Sarah Trott, and welcome back to the Fourth Trimester Podcast. I have a great topic for you today. We're talking a little bit about the economics of the fourth trimester and different models of care for your postpartum experience. And today with me talking about this, I have a special guest. Her name is Dr. Sonal Patel. She is a board-certified pediatrician, neonatologist, and she's the founder of NayaCare. And she is all about the fourth trimester, which is perfect for this show and for this conversation. And we all know how critical this period is for parents and for families immediately after birth, and how it really sets the tone for the lasting experience of parenthood for that family. And so I'd like to say welcome to you, Dr. Patel, and we're so thrilled to have you.
Oh, thank you so much for having me and making this show and highlighting the importance of the fourth trimester.
Yeah, thank you. Well, I'm really thrilled to have you on. By the way, I should mention you're a TEDx speaker as well, and you've talked a little bit about this topic before in that forum and others. But go ahead and introduce yourself for us.
Yeah, so my name is Sonal Patel, and like you said, the the bylines are usually, pediatrician, NICU doc, but I think the most important byline is I'm a mom of four, and that allowed me to literally experience postpartum in every facet. Then I'm also married to my college sweetheart. He is also a physician. He's trauma ortho, and those things are just so much more important because definitely when you look at it on paper, we're both two busy individuals, but we're raising four boys and we've been together, I think, since we've been 18. And I think that's very unique. It adds to the validity of my work as well. And then I can bring the credentials from my career together. It's been an incredible journey, I have to say. For your audience, I really always like to prefix my privilege because, as you could see, I have all privilege, and my medical care system failed me. And we can dive into how that happened as well. And I always reflected back when I started this journey, and even in my TEDx, like if I was struggling so much and with all the education, the financial security, supportive family, even my Indian culture, like we highlight this nesting period. Like I had so much suffering. So what about other moms? That's how I like to kind of introduce myself.
Yeah, thank you for your introduction. And it would not, well, I don't think you would be surprised, but a lot of people are surprised how many perinatal professionals come on this program and say pretty much exactly what you just said, which is because I'm a lactation consultant, because I'm a doula myself, or because I'm XYZ, I thought it would be easier for me. And it just isn't.
Yeah. I didn't think it might be easier, but I thought I'd had access to care a little bit better. And I think that's the nuance of it. So it might not have been technically better in that visual, but definitely having better access to care was not something that I thought there'd be barriers to.
And what kind of care are you referring to? Let's get really specific.
Yeah. So let's just kind of, in order to answer that question specifically, let's kind of just step back a second. So 4 deliveries, C-section, I always say it's abdominal surgery with a baby attached because they go through 7 layers, followed by my second was, then I had 3 VBACs. My second was a forceps delivery, grade 3, grade 4 tear. Then I had an all-natural delivery, barely made it to the hospital. I always joke that, the headline would have been NICU doc delivered in the parking lot. I knew the security guard. That's the only reason I made it to L&D, to be honest with you. And then the fourth was VBAC again, epidural, have our grade 2 tear and preeclampsia into postpartum preeclampsia. So the care that I'm talking about is for myself. And I did all these deliveries and then I said, oh, you can come back at 6 weeks. And it's what happened with every single part of these cares. My body was healing as well. And I still went to care for my baby. And sometimes I would tell the pediatrician, hey, I'm not doing well, but they weren't equipped to handle me and my symptoms and my emotions and how I was doing. And that's the care I'm talking about. Fast forward to now, I mean, the some of the care that I did not receive or knowledge even has resulted in me having some chronic pelvic issues. And I think a lot of mothers deal with that as well. And, this notion that when you cough, it's okay to pee. And when you quickly learn that is not the case at all. Like that is a quality of life that sometimes gets robbed from us. So specifically was my care was very lacking.
Okay. So it's the care for you, birthing person, mom, postpartum.
Yep. And then as a pediatrician, why is that so important? Is because when you add data to all of this, the foundation of that infant, child, teenage, adult development all really stems from the mother. And it's not only in the form of breastfeeding or the choice that you want to feed, but it's also the mental health aspect of it. And that sometimes is overlooked or not even able to be supported in a system that just seems that you get care 10 to 15 appointments in pregnancy. Then thereafter, when you look at the numbers, you get one appointment at 6 weeks. And then across the nation, 40% of women don't even go to that appointment. So there's something very lacking in really creating that foundation. And when that foundation has cracks, child has cracks. It's literally that simple and that in tuned.
So much can happen in 6 weeks.
Oh my God, definitely. Definitely. And I think that's why we call it the fourth trimester, even from the medical lens, is because simply acknowledging that there's another trimester and there's actually a biological evolution reason for it, then we can add the medical care to it and then say that, okay, so for example, I always talk about nursing and breastfeeding and all of that good stuff. Well, for me, in one of my pregnancy postpartums, I had uterine infection and I was almost readmitted to the hospital. And luckily my mom's OB, so she was there. But I was put on powerful antibiotics. So in most cases, when you're separated from your infant, it's hard to nurse. Like there's the attachment, there's a medical aspect of it. And then now lactation has come so far, but previously, I mean, even 10, 15 years ago, there were so many reasons that your milk needed to be dumped. And luckily we've gotten way away from that to realize that that is not the case. But that's very mentally strenuous. And then you're still physically trying to recover. So there is a medical, professional, biological reason that this care needs to be done together rather than separated that we have in our current medical system.
And what would that care look like?
We refer to it as dyad care. So that means is taking care of that mother birthing person or even adopted person and then the newborn in a collective fashion. And so we're not only just addressing, okay, go in there and do all the newborn checks and, ask the question, are you breastfeeding? And half the people lie on it just because they want to kind of be like, yes, I want to have that gold star. But then you don't actually understand the root of it and you can't even give good advice for it. So we really cannot separate the mother from the baby for another 3 months in medical care. So it would be ideal for both of them to be getting care spontaneously at the same time. And again, it's going back to the idea of that they are connected more than that we have given credence to.
So it's caring for both at the same time and before the 6-week check, right?
Oh my goodness, yes. I mean, let's add maternal mortality data to it now, right? When we actually look at California, you guys in that state have one of the best maternal mortality rates across the nation. And one of the things that is there is most of the patients are under the Kaiser program, and Kaiser sends a nurse practitioner out to most of its births right after. So California has actually done a really good job of looking at where the problems were in maternal mortality from birth, actually from pregnancy, from birth to postpartum, and really kind of creating a system where things could be caught. And that's the importance. So when you actually look at maternal mortality data as a whole in the United States, we rank last in developed countries, which is, it is very distraughting, shocking, sad. I've actually done all the 7 things of grief because I really do think that it's awful when even one mother dies, when it's preventable. And then you add the fact that when you look at this data, 17%, most of them are dying in the fourth trimester. So you have about 33% dying in pregnancy of the maternal mortalities. And then thereafter, you have the majority of them, that's like 66% dying in thereafter birth. And when you even break it down, the first 6 weeks is 52%. And again, when I went back to like 40% of women don't go to their 6-week appointment. So we're losing a lot in that. We're losing a lot. Just even maternal mortality. And we don't even talk about morbidity, right? We don't even talk about morbidity. Like, for example, talking about birth and birth trauma. And birth trauma could be as simple as mentally things did not go well, though you can justify it in your head, but you don't have the space to be like, well, that kind of sucked for me. And sometimes you just need that validation, right? You don't need to have mental health crisis all the time. You just need a validation like, yeah, that didn't go the way I wanted to. And it's okay for me to have that grief for it. And it's okay for me to have this ability to voice it, to all the way to, I had a C-section and I needed physical healing. I mean, think about it. You had abdominal surgery and you have 7 layers to go into. And any other time you have surgery, abdominal surgery, you're given bed rest, right? And you're not have a human attached to you that you have to take care of. So we hardly do a good job with mortality and morbidity. We're losing. We don't even have a system to catch it, to be honest.
And with numbers like these, new and expecting parents might start to ask, well, what can we do to have a better, more successful outcome?
I think the first thing is to really be aware of these outcomes and realizing that these exist, and to have a frank discussion with your OBGYN, with your nurse practitioner, whoever, your midwife, your home birth, and really have an open discussion. And not only just for the mother, but also the father to be involved in that aspect of it. Because I always say we barely do a good job with moms, and fathers are impacted as well. And to really have those open discussions and know, okay, like if X, Y, and Z happens, do I have the knowledge to be like, okay, I can take care of it. So for example, my C-section, my OB saved my life and my baby's life. Like that is, at the end of the day, we would not be here. The thing I needed more knowledge about was pelvic physical therapy, realizing that my pelvis had changed so much and that maybe it was not a good idea to go running at 6 weeks because my pelvis did not do well. And now I'm dealing with those aftermaths. I think the knowledge is just so much more important, and people to be aware about it.
Uh-huh. And if people want to be proactive about making sure they're getting seen and getting the care that they need prior to the 6-week check, what can they do?
So ACOG has actually come out and outlined when you needed to get checked. So again, go onto their website and say, hey, okay, this is there. Then you need to know one of the things I've put out is called post-birth. So it is an acronym that describes, right after birth, if you're having these symptoms post POST versus birth, like if you have to call 911 or if you have to go, you can call your provider or practitioner at that point. Really to print that and put it on your refrigerator as a magnet or something so everyone is aware. And then the most important thing is do not doubt yourself. And I see a lot of moms doubting their symptoms or negating it or justifying it. Don't do that, because I think one of the things is that we've created so much barrier to care sometimes is that, patients feel that they can't just pick up the phone and call. And that's another barrier to work with. So do not in the postpartum undermine your symptoms, because sometimes those symptoms can go show really severe. It reminds me of a patient I had. Her name is Sarah, and
Not me,
she literally,
different Sarah.
no, it's different Sarah, not you. This isn't said. This is different Sarah. And, she really showed me a lot. She taught me a lot. So she had hired me because her neighbor had hired me. And she said, you know what? I wasn't successful with my breastfeeding with my first baby. I want to do an in-home, all of this stuff that you're telling me. Let's do it. Perfect. I walk in and I usually see them after they leave the hospital, and she's complaining about neck pain. And it's like, okay, well, let's do your babies. Let's deal with the neck pain a little bit. We kind of did a little sidelining breastfeeding just to kind of give her a little bit of a relief from her pressure. It was over Labor Day. And I said, okay, well, I'm going to come back on Tuesday, but, just call your OB. So checked with her over the weekend. The OB had given her muscle relaxant for the neck pain. And then when I went to see her on Tuesday, she's still it wasn't great, and she wasn't walking well. She just wasn't. And we took her blood pressure, and that's what showed it. And the thing was that I was privy to her at the house and really acknowledged the neck pain while it was dismissed by the OB providers, and they gave a muscle relaxant. So she's fine. We've done a whole study thing on her. I just want to reiterate that. But she did end up having an embolus in one of the bigger arteries that supplies her brain. And then boom, she was put on stroke watch. And the only thing was that she kept calling to be like, hey, I have neck pain, And so now I always say, for your baby shower gift, put a blood pressure machine in there. Do that. We just have to be more active with it. It is our own health. We know the science behind it. We know the research. We know how women's healthcare has always been on the back burner. Even research has been on the back burner. I think we're just tired of it. And we're just like, you know what? We're going to take this in our own hands, and we're going to change the system. So why not?
Yeah, no, I love that. In fact, we've had another guest recently, Dr. Amanda P. Williams, on the program. She said the same thing. She said, if you're going to ask for anything for your baby registry, it's 3 things. It's a breast pump, a doula, and a blood pressure cuff. Make sure you have those things. And the doula, to your point about making sure you're seen in the home and your environment, while they're not a medical professional, if you have someone visiting your home postpartum, good ones who have seen hundreds of births and in different situations will be able to spot the flags and be able to bring in the right professionals and refer you, because they'll have a good Rolodex of contacts, and then they'll know when to send you to go see someone.
And then if you can't afford a doula, also one of the things is having your sisterhood. And that is kind of important too, because your sisterhood will also start identifying things in you, especially with postpartum depression, or, when you feel overwhelmed, which you can't even voice. And sometimes that sisterhood has a different, unique way of getting to you rather than, your partner or your father or your partner and whatever the other person might be, because sometimes they're just too close to the problem and they can't sometimes see it either. So yes, definitely. And can I put a plug in, please? So if you are getting a blood pressure machine, we are doing a study called the Sandy study. And listen to this thing too. I was shocked by this. Again, shock, surprise, whatever, saddened about it. But there's only 2 studies in the world that have actually documented what postpartum vitals looks like. And so I know, really? Right. Yes.
Is that right? Oh my goodness.
Yeah. I was flabbergasted. So when we talk about blood pressures and stuff like that, when you actually look at the studies, you are selecting for a particular patient population, a particular criteria, someone who's had blood pressures before, you might be an African-American mother. So everything is being selected for. So when you go back and you're like, but what is normal, right? Like, what is normal? And should I be worried about this or should I not be worried about it? And then with that question and help with Sarah, going back to Sarah, my patient, she had no red flags for having blood pressures, none whatsoever. Like her first pregnancy was fine. Her second pregnancy after she gave birth. And the only thing in her red flag was like, oh, you know what? We had a little spike in blood pressure right at the delivery. Well, that's kind of normal, right? Because you have cortisol rising and you can justify that. And it was her that put us down into this like rabbit hole. So we're doing a study. We compensate. It's $100 Amazon. It's pretty simple. So I know we're going to do show notes and stuff, but please, if you can help contribute to women's health and you're postpartum and you're in your third, please reach out. And yes, and we can go from there.
Yeah, we'll put a link in the show notes. And also, I wonder, the other thing is like headaches. Like you don't like things that are seemingly small. You don't want to dismiss that, right?
Yes, and most of the reasons is so again, it's not to like frighten anyone. It's just for everyone to be aware. Like you're not going to all end up like Sarah. Like it's not going to be that devastating, but like for headaches, it's most likely you don't have enough electrolytes and enough water. Now, do your most how we teach. I teach a lot of stuff too. I was like, do the least intervention before you going to the most intervention, right? The least intervention is like most likely you haven't either drank, you don't have, or you might, we do a good job of drinking, I'll take that back, but might not have enough electrolytes in there. You might not have enough calories, and people dismiss how much calories because they always latch on to that 300 to 400 that you need for lactation. But also, and especially in the first week, if you had a C-section, that's another 500-600 calories that you need to heal your body. And then on top of that, you need calories to, to make milk for some other human being for their survival. So the first week, I think people really underestimate. I always say first 2 weeks and then allow your body to heal. So it could be as simple as, I didn't take enough nutrition. I haven't taken enough water. I need to give some electrolytes. And then if it's not subsiding, or if it's a headache that you're like really concerned with, call. Like that's the other thing, is that we're not very good at asking for help. And we really dismiss all our symptoms. We're like, oh, you know what? I'll just take some Tylenol and an Advil. Fine, do that. But if it still continues, there's a reason, your body's telling you something. So please don't dismiss it.
Yeah. Thank you for that. I appreciate that. It's like, do what you can, take the natural, normal steps, but pay attention and don't dismiss it if it's something that's persisting. Yeah.
Yeah, exactly. So this is not more fear mongering. It's just making you guys realize that this is self-care. When I say this is self-care because it's like putting your health, also knowing the fact that your health is so important for your infant, child, teenage development. And I love it when I say it is for your child, because every mother is going to be like, oh, I'll do it for my child. But if you say it's for you, then you're like, well, that could be in the back burner part of it.
Yeah, for sure. Well, did you want to talk a little bit about the economics of postpartum?
Yeah. Oh, I would love to. Okay, so in order to understand economics, we're going to go back to GDP. And GDP has actually been, people might have heard about it a lot, but GDP basically is a benchmark for how economy is doing of a country. And what happened was maternal mortality also added to the GDP. So it's not infant mortality or infant health is a little bit lower. Paternal health is not an equation in there either. And it's maternal mortality. So there's actually a history behind it. And it is for colonization. So what happened was that in the turn of the 19th century, when United States and Britain and France and the first world countries were colonizing a lot of the second and third world countries, they realized that they needed to pay attention to women's health. And it was for a pure capitalistic reason. Women make the babies, i.e. the workforce. So this is how maternal mortality over the years over the century actually got connected to what GDP is. It also is a reflection of the social status of a country also. If the woman is happy, the family's happy. I mean, we've all heard this, right? We're just adding research and numbers and data behind all of this. So then when we look at maternal mortality and say, okay, what is the economics of it? So if you actually look at the absolute numbers, currently it's about 1,700 to 1,800 moms that die in a year in the United States. So you're like, okay, well, that doesn't seem a lot. So why are we making such a big deal about it? And why it doesn't seem a lot is because a lot of more women die from cancer and heart disease in a particular year than it could be from maternal mortality. Then you have to sit back and say, okay, what is so critical about maternal mortality that we have put it on a pedestal that we're like, okay, it's a GDP. Like, why is that so critical? The criticality is because it influences not only the immediate economics of that family, but also generational. So let's take, for example, a stay-at-home mom, because we usually think about career moms in the state, but let's take example of a stay-at-home mom. This is her first baby. Unfortunately, she passes away. Now, her partners, i.e. the father, well, do they have paternity leave? Do they not have paternity leave? What's the burden of that person just all of a sudden leaving? And it's also very unexpected, right? No one expects you to get pregnant and then the mom passes away. So one of the most immediate costs is funeral cost. I mean, that is something very concrete. And funeral cost, depending on where you live, can be very expensive. Now you have to take care of an infant. What are we going to do with this infant? Okay, who's going to raise it? How am I going to support it? So that's a generational. Now let's add to that picture a career woman. Let's say, okay, this woman she works as an epidemiologist at CDC. True case, by the way. And she has done 10 to 15 years of research under CDC as an epidemiologist. She gets pregnant. She dies because of high blood pressure. Well, now you have an infant that needs to be taken care of, the immediate thing. But her value, her economic value, has been just disappeared in a snap. What happens to her research that could have brought valuable information? She's a person that contributes to the economy as well, and that's kind of gone away. So when you start peeling this out, you realize what impact that 1,800 moms really have. And then you add to the fact that some women have passed away with their second or third, or even their fourth babies. And that person, that mom, not only is the mother's taken away, but they're probably involved in their community. They're probably involved in their church. They're probably involved in their school. They made a difference to the community. And that value can't even add on to what that number is. But it is a domino effect when a woman dies due to maternal mortality, which is even more for breast cancer or heart-related diseases.
Wow. Yeah. I appreciate that overview so much. I mean, losing someone is just so tragic in so many ways. And it's an interesting view looking at it from the economic side of it as well. So what do we need to change? How do we need to improve maternal mortality?
That is a nice big question. Wow. Okay. Since I am an expert on this, I will answer it. And I can only answer it from my lens in the sense of the medical system has to change. Like it literally has to change. We are losing mothers in the first 6 weeks. We know it. We know the data. We need to do dyad care. So that's one. So on a medical system level. Then policies, right? California has a great paid medical and family leave. Paternal leave is so important as well. I know California has that as well. We don't have that universally in the United States. The United States is one of only 2 countries in the world that does not have it. And when you actually look at other countries that have lower rate of maternal mortality, let's say Finland, Sweden, the Norwegian countries, they all have paid family leave. So that's a policy aspect of it. Then you're like, okay, well, those are really big things that need to be changed. What can we change acutely? Blood pressure machine. I think that's an amazing idea, right? Because that's putting your healthcare back in your hands and saying, okay, I know this is not for a fact. The education of it, doula support, womenhood support, sisterhood support, taking back this narrative, what postpartum should look like and really calling it the fourth trimester. And I'll get to that in a minute because I think the language is so important. So those are things that we can happen at the individual levels in order to change maternal mortality at a very national level as well. So there's a lot of moving parts that need to happen. Now, going back to why we have to stop calling it postpartum, because I always do this thing. If I say postpartum, what does that evoke to you? Like, what kind of emotions does that evoke to you?
Well, often people confuse the word simply as being the equivalent of postpartum depression. They don't know that the word simply means after the period after giving birth.
Right. And it's also because it's associated with postpartum depression, it feels very heavy.
Yeah.
Like, oh, I'm postpartum, like it feels heavy. And when you say, oh, I'm in the fourth trimester, it feels more lighter. It feels like you can do whatever you wanted to do when you were pregnant. Like it brings a quality of like, I'm in fourth trimester.
Yeah.
So I am very big on that, with every type of anything, everybody will go through the fourth trimester period. It's postpartum is what we're trying to prevent. So meaning we're trying to prevent maternal mortality, we're trying to prevent maternal morbidity, we're trying to prevent the postpartum depression, we're trying to prevent breastfeeding issues and stuff like that. We're trying to prevent all of that. But everybody will go through the fourth trimester. Even if you're a NICU mom, you will go through the fourth trimester because it's our hormones that are doing in our body. And then boom, it changes it to be like, oh, mom and the babies are attached. That means we need to treat them as one instead of separating them.
Thank you. I know I asked a really big question there. And
yeah, I hope I answered it.
yeah, no, you did. You did. Some of it feels very big and out of the control of the individual, right? We can vote and there are things we can do to influence in our community and policymaking. But then the things that you can do that are just very accessible, right? You can go and buy a high quality blood pressure cuff and have that at home. Yeah. You can hire a postpartum doula, or you can have a friend or family member, or you said sisterhood, right? You have someone from your community who you trust, who will listen to you without judgment, who can show up for you and be there and be present in your fourth trimester.
Yes.
Right. So that they can help keep eyes on you and help look after you. So I think those are some of the things and you also touched on advocacy, on advocating for yourself. Don't just dismiss things. Like that seems very actionable for individuals to take to heart and listen to yourself and trust yourself. Don't dismiss your inner voice. So I appreciate all of that because it was the sort of the bigger picture and then very actionable things that people can do.
I mean, honestly, it's like, I think baby showers and first birthday should celebrate mothers more. So do you really need that $30 cute outfit that your baby's probably not going to wear in the newborn period? Or can we spend $30 on a blood pressure machine, to really start rethinking both occasions and, just even doula, midwife care, even like a nurse nanny, like why can't we? And the problem is that we get bombarded too, right? We get bombarded with so much materialistic things that services, though, because it's not materialistic, right? It's a service. And sometimes we can't see the value of the service until the service is there. But I'm telling you, whatever Sarah you've said, yes, these are the things that are going to change postpartum care or fourth trimester care. And another thing that we haven't even hit upon is that it is a very hard period to go through. You're in survival mode. Yeah. It's not just you also, it is also your partner and the father, and they're in survival mode too. And if you don't have ways and you don't have concrete ways to kind of reconnect, I always say it's your introduction to parenting. And how are you going to reconnect from that level to continue to reconnect? Because having children, there's plenty of stresses in life, but we have to figure out from the get-go, okay, how do we connect together? And I don't know, maybe it reduces the divorce rate. I don't know. Like there's so much more value in this fourth trimester than just, we're going to just change the wording.
And your point about mental support earlier, we had an OBGYN give some great advice, which was make your appointment with a mental health care provider while you're still pregnant for a few weeks after the birth. You can be a virtual visit, right? You don't have to leave your home, stay home. But having that check-in on the calendar makes it so much easier to just make sure that you're being looked after and supported in the way that you need. You don't have to wait until you feel signs of the blues or depression or have something be wrong. It's actually more of just maintenance, right? You could be feeling great, but it could be wonderful to have someone to talk to. So I like that advice too, only because sometimes it can be really hard to find a provider, and then maybe they have a wait list for appointments. So if you are in a situation where you do really feel like you need that support, you don't want to be waiting 2 months for that first appointment. So I really appreciated that
definitely.
too.
Most definitely. Yeah. It's all about prevention, right? Why are we not focused on prevention as opposed to now we're in crisis and it's acute, so now we're searching and we can't find access to care.
Yeah. Yep. So Dr. Patel, this has
Yes.
been an amazing conversation. Do you have anything else that you really want to touch on or some final words you want to share?
Yes, I want to change the narrative that postpartum is hard. If you have the right support, it can be a beautiful, beautiful time period. It is hard in the sense that your body is going through so much changes. I mean, I love the word matrescence. I know you might have hit upon matrescence, which is the birth of a mother, and really to kind of value yourself. And one of the tricks that I do for my moms is I will literally say, all right, I'm going to say Sarah again, not you, Sarah, another Sarah. I'll say, Sarah, hey, you are 32 years old. You just had a baby. You have a toddler running around as well. What would you say to your friend? And it changes that mindset for them to realize that they would treat their friend much differently than they're treating themselves right now. So that's one thing that I always want to convey. And it can be a very beautiful Hollywood Hallmark time if we can do the prevention and get the right support. And I've had moms tell me that. They literally have questioned, is it okay for me to enjoy this? And that breaks my heart too.
Thank you for that perspective. Yes, you can have a joyful fourth trimester.
Yes.
Absolutely. Yes. Well, what a wonderful resource that you provide for your clients. And where can people go to find out more about you?
I'm on all social medias. I do like TikTok, by the way. I don't dance, but I have good information on there. LinkedIn, and then definitely our website, which is NayaCare.org. And yeah, come find me, come connect, please. I call it a movement, and I love these opportunities because it's such a huge movement that's going to take all of us to change it.
Very, very true. Wonderful. Thank you. We'll have links to all of those places that you just mentioned in our show notes so people can find you and connect with you. And I want to say thank you to all of our listeners for joining us again, and we'll see you next time.
Thank you.
You can subscribe to this podcast in order to hear more from us. Thank you for listening, everyone, and I hope you'll join us next time on the fourth trimester. The theme music on this podcast was created by Sean Trott. Hear more at soundcloud.com/Sean Trott. Special thanks to my true loves, my husband Ben, daughter Penelope, and baby girl Evelyn. Don't forget to share the Fourth Trimester Podcast with any new and expecting parents. I'm Sarah Trott. Goodbye for now.
Hello again, bicycle man. I know you're doing all that you can. I wrote the song, simple and true. I wrote the song, I'll sing a song for you. You got your wheels, you got your gears. You ride around town without any fear. You got your pedals, you got your brakes. You always wear your helmet for safety's sake. Hello again, bicycle man. I know you're doing all that you can. I wrote the song, simple and true. I wrote the song, I sing a song for you. Hello again, bicycle man. I know you're doing the best that you can. I wrote the song, simple and true. I wrote the song, I sing a song for you.